how can we use ultrasound in nephrology? Well, right from the time the patient first presents to us, the patient may be in acute renal failure, progressing on to CKD, getting a transplant, and finally, for diagnosis, if you have obstruction, if a patient presents with pain or hematuria, and then for us to have guidance to do our kidney biopsy. And if all else fails, and I'm a big proponent of peritoneal dialysis, but if the patient is not a candidate or has a contraindication to peritoneal dialysis, the patient goes on to hemodialysis. And how can we use the ultrasound in AV fistulas, AV grafts, and central venous catheters? So briefly, I'll just touch upon some technical considerations. The kind of ultrasound that we commonly see is the B-mode ultrasound, the grayscale imaging. And this is based on the fact that sound wave travels through the tissue and is reflected back into the transducer. And you get a two-dimensional image. You can also do a color Doppler. And one thing that everyone must remember, a color Doppler is not a quantitative measurement. It's a qualitative measurement. It gives you two informations. One is the degree of color saturation. As you can see here, you've got it going from yellow, orange to red, and then the greens and the blues. The degree of color saturation gives you an idea of the velocity of flow, but not a number. And the hue is the direction of the flow, and it's an easy mnemonic, BART. When you look at it, blue does not mean venous, red does not mean arterial. Blue means away from the probe, and red means towards the probe. And then if you do want to do a quantitative analysis, you can use the spectral Doppler, and this is what you have, a waveform. You have velocity, and then you have time. Time on the x-axis, and velocity on the y-axis. And this is where you get your quantitative measurements of peak systolic velocities. And then if you have low flow or occlusion or near occlusion, you use the power Doppler, where the power of the signal is related to the number of RBCs, not the flow. So starting off with the renal ultrasound, we use this in diagnosis quite often. And I don't need to tell this audience about the anatomy. But if you take a look at your picture on the right, this is what a normal renal ultrasound should look like. So you compare, this is the liver. You try to get it in the same window as the kidney. In the kidney, you can see that you want to look at the echogenicity of the cortex. So when I say echogenicity, that means how white or how black the ultrasound looks. So if this is the liver and you can see the cortex of the kidney, that looks darker than the liver, that's the way it should be. So it's not an echogenic kidney. And then you want to find, this is the cortex, this is the medulla, which is overlaid by the sinus fat, which is echogenic. So you have maintenance of your corticomedullary differentiation. And then you move on, when you do your ultrasound, in this particular ultrasound, you can actually see, and I'm not sure how well it projects to the back of the room, but you can see the medullary pyramids right here, and then this is the renal pelvis. Once you take a longitudinal view, and I'll be demonstrating all of this in just a few minutes, you also take 3 transverse views at the upper pole, the middle pole, and the lower pole. And how can we use this information? So if you have a patient that presents to you with an elevated creatinine, the patient could be in acute renal failure, or this may have been going on for a while without us knowing about it. So if you look here, this is a patient who presented with acute renal failure, absolutely normal kidneys. Patient may have ATN, patient may just have glomerulonephritis, at which point you would go ahead and do a kidney biopsy, which we'll talk about in a little bit. But you have a patient that presents with acute renal failure, and you see this pattern. So you can see that the renal parenchyma has been pushed. The medullary pyramids are really dilated. The key is not only are they dilated, but they are connecting with each other, and the renal pelvis is also dilated. So this is classic of hydronephrosis. Then you have a patient that's presented to you. They have not had care for a long time, and you see this kidney on the ultrasound. You know that this has been going on for a while. This is a classic CKD kidney, a relatively small kidney. As you can see, very, very echogenic. The liver is right here. a very white kidney, you have loss of your CM differentiation, and some of the cysts that you see later on in your disease. So this is a patient that you may actually start preparing for dialysis because you know that this has been going on for a while and there is possibly no reversibility. And then this is another situation that may mimic to the inexperienced person hydronephrosis, but this is actually multiple cysts that we see in autosomal dominant PKD. And most of my patients with PKD, we are a referral center for PKD, and they have kidneys that are 25 to 30 centimeters long, going down almost into the pelvis, and all they have is multiple large cysts and almost no cortex that's visible. And then if you have a patient that presents with pain, with hematuria, and you do the ultrasound, and you see this echogenic focus, and you see a shadow that comes behind it, this is possibly a kidney stone. So, and this acoustic shadowing is very important. Sometimes you may just see minor calcifications without the acoustic shadow as well, but this is obviously nephrolithiasis. And then the patient, if you see a transplanted kidney, you can use it both for diagnosis as well as for biopsy. Obviously, a biopsy of the transplanted kidney is a much easier biopsy than a native kidney biopsy because these are more superficial. But the key factor, again, to remember is that the medullary pyramids do appear dilated in a transplanted kidney because it's closer to the skin surface. But because there is no connection and there's no, this is not a hydronephrosis picture. And then you can also use the ultrasound to look at the bladder. We have ways on the ultrasound where you can actually measure the post-void residual, and it's based on the formula for an ellipsoid. And if you have a bladder like this, you ask the patient to void, and then you measure the post-void residual. If it's less than 50 mLs, then you know that the patient is not obstructed. And you can also look at your Foley catheter placement. And again, we'll go over all of this in a few minutes, but just briefly wanted to touch on a renal biopsy. And all of us at our institution, we do our biopsies at the bedside. When I trained 20 years ago, Dr. Narula used to do them blindly, and I think we leave that to the masters, but all of us now use ultrasound for guidance. And we do it at the bedside. It's really, you know, it takes out the difficulty of trying to coordinate with the radiologist, trying to figure out, and they're always trying to turn down a procedure for some reason at our institution. So we just do it at the bedside. The key thing that I think we need to remember is the positioning. So the spine is normally curved, and what you need to do is get rid of the curvature. So you have to make the patient flat. They need to be in the prone position. And if this doesn't work, you just put a little pillow under the abdomen to make it absolutely straight. And then the goal for the kidney biopsy is to do the cortex of the lower pole because that's the least vascular, your least chances of complications. And so what you're trying to do is aim for this particular area. And how you can do that by the ultrasound. Now, keeping in mind the kidney is retroperitoneal, and it moves a lot in some people with inspiration and expiration, you have to find the right place for you. So if this is, whether it's end inspiration, end expiration, or the patient is just holding their breath, you need to figure out, it has to be a straight shot. Each of these dots is 1 centimeter, so this is around 5 centimeters deep. I usually, for patients who are deeper than 10 centimeters, I will not do it at the bedside. But 8 to 10, less than that, it should be easily done at the bedside with a low risk of complications. And so once you have it in the long view, then you take a transverse view, and you want to make sure that you're only seeing the lower pole. You should not see the hilum. You should not be seeing anything that you see in the mid pole of the kidney, and confirm that you're in the right spot, and then you go ahead and mark it. Now, you can do the ultrasound 2 ways. You can do it absolutely real time, put a sterile probe over it. We use the ultrasound more as a guide than as a real-time ultrasound. And so this is how this is one of our fellows. This is how we do the procedure. We actually use the ultrasound to mark it, and we just use a coffee straw to mark it because that leaves an indentation that after you clean the patient, that indentation is still there in case you were using a permanent marker. and then you numb it up. Now keep in mind that when we measured it, it was around 5 centimeters. When you inject the lidocaine, you're going to have another half to 1 centimeter below it. And then a small incision for the biopsy needle or the biopsy gun to go through. And then you use your finder needle. You use your finder needle for 2 reasons. One, you can go a little bit deeper with the finder needle and give more anesthetic. The second is that you actually know you're in the kidney before you use the biopsy gun, which is a larger gauge. And so use the finder needle, do the classic technique that we all learned, watch the needle move back and forth with respiration. And then once you're sure you're in the kidney, you're in the right place, take your biopsy needle, and you can get, as you see, really nice cores. You can even see some of the gloms to the naked eye. So that is how you do a kidney biopsy. I'm not going to go over the indications and the contraindications. We all know that. This is just the ultrasound portion of the talk. And then this is how you do the real-time biopsy. You can actually see the biopsy needle going right where it's supposed to in the cortex of the lower pole. So that's how we do all our biopsies. Of course, even with the best of the things, it's not ultrasound guidance that prevents you from the complications. There was a multivariate analysis that was published. The things that correlate with bleeding are obviously bleeding parameters, uncontrolled hypertension, a creatinine greater than 2. So even with the best of guidance, you may still have a complication. Why I like the ultrasound is if the patient is complaining of hematuria, if the patient is complaining of severe pain, or the H&H is dropping, I can just take the machine, and hopefully I would never have to see that. But this is a large peri-renal hematoma that you see, and then you know you need to transfer the patient and do some management and maybe some intervention as well. So the use of the ultrasound is not even just before for diagnosing, actually during the procedure, and then after the procedure. We usually, after we are done with our ultrasound, after we are done with the biopsy, we'll take the ultrasound and just take a quick look. Of course, it takes time for this kind of hematoma to develop before you can see it. And I'm sorry I'm rushing, but we are short on time, and so we're going to move on to vascular mapping. So once you've done everything you can, you've done the biopsy, the patient's been on immunosuppression if you wanted to treat it, and the patient is headed towards dialysis, the next thing we need to do is vascular mapping. So when should you start? And I know there was a lot of discussion in the first session of when we need to start and how to tell the patients that it's a continuum. We need KDOQI guidelines tell us that we need to start early, at least 6 months before you anticipate the need for having a fistula. And of course, our patients need to understand that. And a key factor when we say vascular mapping, I know a lot of people say vein mapping, and I'm guilty of that as well, but both artery and vein are important. And the key thing about the arteries is that there are 2 issues. One, that it should be large enough to provide you adequate flow for dialysis, but also, in a way, technically, physiologically, you're stealing the blood away from the hand or from the wrist. So you need to make sure that if you utilize that vessel, so you need to look at both the radial as well as the ulnar artery, not just the radial artery where you're making the fistula. And a simple arterial evaluation can be done in the office. You do differential blood pressures in the 2 arms. Make sure they're no more than 20 millimeters difference. And then everyone's familiar with the Allen test. Go ahead and occlude your radial arteries and your ulnar arteries and see how quickly, as soon as you release one and then the other, you should get flow back to the hand in 5 to 10 seconds. And if you don't, there might be a problem. When you do the ultrasound, you're trying to look for calcifications, trying to make sure that the luminal diameters. So the luminal diameters for the artery, and this is based on Silva's paper, an old paper of 1998, where he said that they found that the arterial diameter should be at least 2 millimeters and the venous diameter at least 2.5 millimeters at the site of anastomosis. A lot of people now are trying to come up with numbers even lower, so they're saying that you can go ahead and place a fistula even if your arterial diameter is 1.6 millimeters. But I think that we are going to see many more failures if we move our criteria a little bit lower. And then for the vein part of it, we need to make sure not only is the diameter of 2.5 millimeters, but you should have a straight segment, at least 6 to 10 centimeters long, for cannulation. And each time you do the ultrasound, should be looking at continuity and making sure that it's compressible. There's no thrombosis, because a lot of the patients, our patients, get a lot of phlebotomies, and sometimes they get cytotoxic drugs, which can affect their veins. So we need to make sure that the veins are unobstructed. And in my opinion, so when I first started, vascular mapping was not mandatory, and our surgeons, even if we did the mapping, would ignore it. Practice has changed in the last few years, and in my personal opinion, I think vascular mapping should be mandatory before placement of an access. So what are the techniques for vein mapping? And again, I'm only going to talk about the duplex ultrasound today, because it would be great if all our patients have veins like these, but we don't. And so we need some additional techniques like the ultrasound. And this is one of our patients at our center. And the key to remember is not to do it in a cold room. Most of the places are air conditioned, it's a cold area. You need to make sure the patient is in a warm environment, because cold does cause constriction of the vessels. And then what I usually start off with is the arterial evaluation. So we'll do the radial, the ulnar, and the brachial, get the intraluminal diameters, make sure there's no calcification, do your Allen's test, do your differential blood pressures. Then we move on to the veins, and we do multiple measurements along the path of the veins, and then record. The advantage of the ultrasound over angiography, the biggest advantage is the depth from the skin surface. So we have an epidemic of obesity going on, and you have all these patients with huge arms that you need to know how deep and I'll talk about the rule of sixes, but you need to know how deep the vein is before you take it up for an AV fistula, or you may need a second surgery or a superficialization. So when you look at this, so once I do the vascular mapping, I don't just give a report, and this is what I encourage every nephrologist to do, is we give them a plan A, B, and C. So we give them recommendations for what the access should be. And I have a small case that I'll illustrate that with, but basically you want to tell the surgeon, I want a radiocephalic fistula. If that fails, I want a brachiocephalic and then a brachiobasilic, but you have to lay it down because sometimes people interpret it differently. And then the other question is the use of the tourniquet. So there are some people who will start off the vein mapping with sequential tourniquets, starting off here and then moving it up. I do not start with a tourniquet. I will do the vein mapping. If I have adequate numbers without a tourniquet, that's good enough. If I don't get adequate numbers, that's when I'll do the tourniquet and give both the results so we can see that the vein is capable of dilating if there is augmentation. So again, this is a vein mapping of actually one of my residents. And you can see that cephalic vein, radial artery, you can see the flow through that. And this is where you would make the anastomosis. Not where you see the cephalic vein up there, but where it's closer to the artery. So sometimes you have to proximalize your anastomosis. And similarly here, you have the brachial artery and the basilic vein in the upper arm. The one disadvantage of the ultrasound is the fact that if a patient has had previous catheters, you can't really look at your central veins. You can look at your central veins, but it's an indirect measurement because you're looking at the normal or the dampened waveform depending on where the stenosis is or the thrombosis is in the IJ or the subclavian or the brachiocephalic. So if someone has a problem, if someone has had 1 or 2 previous catheters, we recommend angiography rather than ultrasound to evaluate prior to placing an access. And this is a case, and again, I can't see the timer, but I'm just going to quickly go over this instead of, I was going to do this as an audience response, but I'm going to give you the key points of this case. A classic patient, multiple comorbidities, hypertensive, diabetic. You can see that we did the mapping and we saw the arterials were okay. In fact, if you look at the venous measurements, the cephalic vein at the wrist is 2.8, which is well beyond the criteria the minimum criteria that we need. But what you find here is that the cephalic vein is 8 centimeters from the skin surface. And so when you want to make your recommendation, you have a few choices. And I'll just give you the answer. You want to do a radial artery to a cephalic vein with superficialization. So I keep talking about the rule of sixes. What do I mean by the rule of sixes? And I'm sure a lot of the audience is familiar with that, but just for the younger nephrologists, the rule of sixes is what's defined as what we use to define the maturity of the AV fistula. So obviously, most of the times, it's clearly visible on your physical examination. You do an examination, you do augmentation, you do collapse, and you know that this patient is ready for cannulation. But sometimes it's not quite so clear. And so there are some criteria. The diameter of the axis should be at least 6 millimeters. It should be less than 6 millimeters from the surface of the skin. When you do your flow measurements, it should be 600 milliliters per minute, and there should be at least a 6 to 10 centimeter straight segment available for cannulation. So this patient, obviously, the distance is only 0.3. It's a large fistula. It's obviously ready for cannulation. And this rule of sixes didn't just come out of the air. This was based on Robbins' criteria. This was a landmark paper that was published maybe 10, 12 years ago. And what they showed was that if the fistula diameter was at least 0.4, and if the flow in the axis was at least 500 milliliters per minute, if you combine the two, you were able to have a 95% predictive value that that fistula would be successful. And just to make it easier to remember, it got changed into what's called the rule of sixes, so you don't have to remember different numbers. But one interesting point in this article that sometimes we all miss is the fact that experienced dialysis nurses, so if you get your best nurse to look at the axis and she says that they can use it, they can probably use it. And this was actually pretty accurate. So moving on to hemodialysis axis, multiple ways in which you can define or identify stenosis in our patients. You don't need to know all of these, except perhaps if you see a luminal diameter reduction of around 50%, that translates to a 75% reduction in your cross-sectional area. So that's probably a significant stenosis. The other thing I keep talking about is the peak systolic velocity greater than 4, or the ratio. So if you take the PSV at the stenotic area and 2 centimeters distal to that, and you do that ratio, if it's greater than 2, it's likely that it's a hemodynamically significant stenosis. And here's where you can actually see. You can see this is the artery. This is the draining, the fistula, the vein, and you can see the juxta-anastomotic stenosis. And the PSVs that were measured, you can see the PSV at the stenotic site is quite high, and the ratio is greater than 6. So that's a very significant stenosis. And this is another picture, but a similar story. And you can see that this stenosis is confirmed by angiography when you can then do your angioplasty. The axis flow volume, I just put this on for completion. The axis flow volume using the duplex ultrasound is really not reproducible because it depends a lot on the angle of incination, and it's very, very hard technically to get an angle of incination of 60 degrees or less. But just so you know numbers, because some people may be using, and I'm not sure what is used for surveillance here, but we use transonics, which is the ultrasound dilution technique, and we do look at these numbers. It's important to know that fistulas can tolerate lower flows than grafts. So if you have a fistula, and in Japan, they use fistulas with blood flows of around 300, 400. So a low blood flow in a fistula is not necessarily indicative of future thrombosis, as it is in grafts, where as the number declines, your relative risk for thrombosis increases. And then what's the point of doing all this if ultimately you're still going to have to give the patient contrast or radiation, if you're going to have to do your angioplasty under fluoroscopy? So there have been a couple of centers that have started doing angioplasties under ultrasound guidance. We are not one of them yet. But these are small, uncontrolled studies, and it has been successful in both grafts and fistulas. Patients have been done intraoperatively for AV fistulas, as well as office-based procedures. So patients in the office coming to you do a preoperative ultrasound, and then the only thing the authors talked about was the 2 visits that were required for the patient, because they would do a preoperative ultrasound, figure out the size of the balloon that they needed, get that, and then call the patient back. But they had 32 office-based procedures, 27 non-maturing and 5 failing fistula, and very, very successful rates in the office. So this is something that may be coming out in the future in the next couple of years. And then to briefly touch on other things that we can use the ultrasound for. So our access center has always traditionally been an outpatient access center, which is great for the 90% of the patients that you can help, but there are some patients that should not be done in an outpatient setting. And one of these is when you see mega fistulas with a large amount of thrombus burden, because you have a high risk of PE. So these are the patients that should be done in the hospital, not in an outpatient setting. And then if you want to visualize a normal graft, this is what a graft looks like on ultrasound. You have 2 parallel echogenic lines. You can see the laminar flow through the graft, not much turbulence. Graft stenosis is not any different from fistula stenosis on ultrasound. You can see the stenosis and the post-stenotic dilatation. And similarly, the PSVs, very, very similar to what you see in the fistulas and outflow vein stenosis. And where you use the color Doppler or even the power Doppler is where you see the access. I mean, obviously, auscultation is very simple, very easy, but sometimes it gets confusing. Do the Doppler ultrasound, there's absolutely no flow through the access. And you can use the ultrasound if the patient has swelling post-operatively. Sometimes it's infection, and sometimes it's just normal post-operative swelling. You can use the ultrasound in this particular patient. You can see these acoustic shadows. This patient has gas around it. This patient has an infected graft that needs to be removed immediately. And again, pseudoaneurysms that you can see. And I'm briefly going to touch on it. I saw in the schedule that there is a talk on this later on this afternoon. But again, ultrasound guidance, not forgetting your anatomical landmarks, but as an adjunct, must be used. You have the internal jugular and the carotid. The vein is usually compressible unless there's a thrombus in the vein. And so again, very strong personal opinions, but in my opinion, a blind cannulation in today's day and age, we owe it to our patients, should not be done. If you have a complication rate of 5%, that's 5% too many. And ultrasounded guided cannulation at our institution, and I think most across the world, is mandatory now. And this is not just because of thrombosis or not being able to pass the wire, but the fact that over 1/3 of the time, the anatomy is not exactly what you expect. And so you have to be prepared for that, and there's no reason to have the patient go through multiple cannulations just because we're not using a device that's easily available to us. So to summarize, ultrasound is a non-invasive technique. It's widely available, very easy to learn to use, and can be used across the spectrum from renal disorders. From the time the patient first presents to us, till the time they go on dialysis, their time on dialysis, till the time they get a transplant, acute or chronic rejection, you can use the ultrasound, and it's an excellent tool, and all nephrologists should be comfortable with using sonography for their use. And of course, I'd like to thank Dr. Charlie O'Neill. He's one of my partners and the guru in ultrasound, and Jenna Narula. Without him, I wouldn't be here today. So thank you very much for your time and attention.